It's now my pleasure to introduce the Honorable Professor Peter Nyong'o. He's the Minister for Medical Services of the Republic of Kenya and a Member of Parliament from the Kisumu constituency. Between 2003 and 2005, he was the Minister for Planning and National Development, where he played a key role in the implementation of the economic recovery strategy for wealth and employment creation. We know that anytime you want, there's always a job waiting for you in the United States. So he has championed the government's poverty eradication campaign and has been in the forefront of efforts for uplifting the living standards of Kenyans. He's an accomplished academic. He holds both a PhD in political science and a master's in political economy, both from the University of Chicago, a Bachelor of Arts in Political Science and Philosophy from Makerere in Kampala, where he was awarded a first-class honors degree. Professor Nyong'o, it's my pleasure to invite you.
Thank you very much, Ramanan. Unlike my predecessor, David, I'm not going to show slides. I think I'm just going to read from my speech. I belong to the old school. Drug resistance, ladies and gentlemen, in the treatment of various diseases and ailments is a global problem. What varies from one country to the other, or from one system of health delivery to the other, are the following. 1, the type of resistance encountered. 2, the diseases or ailments involved. 3, the genesis and evolution of the resistance. 4, the population affected in terms of status, age, residence, and vulnerability to other diseases. And 5, the steps taken to forestall or eliminate resistance through research, use of new methods of treatment, and preventive measures. In Kenya, malaria treatment has for a long time been the most problematic area in terms of resistance. Malaria still remains one of the leading causes of mortality and morbidity in Kenya, particularly among children 5 years and below, due mainly to the emergence of parasites that are resistant to the cheap and readily available anti-malarial drugs, particularly Fancida and chloroquine. Chloroquine resistance was first noted in the 1980s with 66 to 87% resistance rate. This led to the division of malaria control to replace chloroquine with Fancida as the first line of drug for uncomplicated malaria in 1997. Subsequent research and clinical trials suggested that the reversal to chloroquine sensitivity is slow and that chloroquine should not be introduced or used in combination with other anti-malarial drugs in Kenya. Not before long, however, resistance to Fancida emerged. In the year 2006, therefore, another anti-malaria drug policy change was made in Kenya, switching from Fancida to Coartem. The malaria unit of the Kenya Medical Research Institute has been central in these developments, collaborating with various international organizations, such as the Center for Disease Control from the USA and the International Atomic Energy Agency in these endeavors. Kenya ranks 13th on the list of 22 high-burden TB countries in the world and has the fifth highest burden of TB in Africa. According to the WHO Global TB Report of 2009, Kenya had approximately more than 132,000 new TB cases and an incidence rate of 142 new sputum smear positive cases per 100,000 population. Kenya's National Division of Leprosy, TB, and Lung Disease began to implement the WHO recommended DOTS, the International Recommended Strategy for TB Control Strategy, in 1993, and reported 100% DOTS coverage by 1996. In the year 2005, the DOTS case detection rate reached WHO's target of 70% and rose to 72% in the year 2007. Problems have, however, been compounded by multi-drug resistant TB in Kenya since 2007. Reported figures may be low due to limited access to proper diagnostic facilities, particularly among the poor in urban slums, where possibilities of drug resistance are much higher. The National Leprosy and Tuberculosis Program and the National HIV/AIDS Program work together to confront problems of TB detection and control, as well as the menace of drug resistance arising mainly from the prevalence of HIV/AIDS. Community-based programs are undertaken to facilitate awareness, prevention, control, and treatment. That notwithstanding, the emergence of extensively drug-resistant TB has in the recent past complicated matters for researchers, policymakers, health providers, and patients. Some contend that extensively resistant TB, drug-resistant TB strains have emerged from the mismanagement of MDR-TB. Whatever the case, the issue now is how to detect the source of the problem, prevent its further spread, and treat those already affected. Research done by Githui and others and reported in the International Journal of Tuberculosis and Lung Disease in 1998 came to the conclusion that the initial drug resistance are still rather low in Kenya. The increase in acquired resistance to isoniazid requires monitoring. It is the results of this monitoring since then that should report on the extent and significance of extensively resistant drug resistance TB and its toll on healthcare delivery in Kenya. Due to access to antibiotics and other drugs over the counter, prevalence of counterfeit drugs due to Kenya's porous borders, and the limited ability of the regulatory agencies to rein in unethical distribution and use of counterfeit drugs, drug resistance to other diseases such as upper respiratory organ infections has also become highly prevalent. The extensive analysis of this resistance to other diseases is contained in the situation analysis into antibiotic use and resistance in Kenya, done by Dr. Samuel Kariuki and his colleagues. I hope Dr. Kariuki is here.
He cannot make it.
He cannot make it. But anyway, this is a very useful document that I think is in your package that will give you substantial information of antibiotic use and resistance in Kenya. Recently, ladies and gentlemen, the Pharmacy and Poisons Board, a regulatory agency under my ministry, has been under tremendous public pressure to be more effective in the spread of drug resistance through the misuse of antibiotics and the access to counterfeit drugs. The Ministry of Medical Services has also taken drastic measures through the Medical Practitioners and Dentist Board and the Kenya Medical Laboratories Technicians and Technologists Board to ensure that pharmacies, laboratories, clinics, and all other service providers perform quality work and follow regulations. The jury is, however, still out on what successes we are making in this regard. While the Kenya Medical Research Institute remains the premier institute for research on drug resistance and how to undertake preventive measures to forestall resistance. The strategy to prevent, limit, and control the genesis and evolution of resistance needs to be a collaborative effort involving all sectors within the healthcare delivery chain. Elements of this strategy should include the following. 1, vaccination to prevent illness and reduce demand for antibiotics. 2, aggressive hospital infection control, including proper sterilization of linen, tools, instruments, and equipment to drastically limit in-hospital infection. In this regard, my ministry has, over the last 3 years, undertaken a baseline survey of all our hospitals in the public sector to find out, 1, the situation with regard to infrastructure and human resources. 2, what we need to improve this infrastructure and human resources to deliver health services effectively, and therefore the total amount of money government should put at the disposal of the ministry in the next 5 years to fill the gap between what we have and what is optimal in the delivery of healthcare. Our estimation is that we need at least $1 billion in the next 5 years to improve hospital infrastructure and human resources needs, so that such things as in-hospital infection due to lack of equipment and trained manpower for purposes of sterilization and proper use of hospital facilities is met. 3, judicious prescribing and cycling of antibiotics. 4, treatment with narrow-spectrum antibiotics. And finally, the development of new and suitable antibiotics under a coordinated national, regional, and international policy that stewards this resource, preferably with the World Health Organization, working closely with governments, consumers, and pharmaceutical companies. Thank you, ladies and gentlemen.